everybody. Welcome to the Annual Research Day hosted by Parkwood Institute Research. My name is Sarah Husney, and I'm the research coordinator for a project called Homelessness Counts. Dr. Cheryl Forchuk is the principal investigator. The title of this presentation is Getting the Data on Homelessness, Key Findings from Year 1 and 2 of the Homelessness Counts study. Given that the theme of this year's Research Day is all about the power of partnerships, I thought it was fitting to include this slide, which highlights the many different people involved in the Homelessness Counts project. Partnerships and collaborations are an integral part of all of our research studies. Before we get started, I'm just going to take a moment to highlight our funders for the Homelessness Counts project. We wish to express our sincere appreciation to the Public Health Agency of Canada and to the Government of Canada's Reaching Home program for their generous financial contributions. The aim of the Homelessness Count study is to access and integrate existing sources of information to better determine who and how many people across Canada are experiencing homelessness. Our past work has included developing an algorithm using health databases and seeing if that could be used as an alternative to better determine homelessness. In 2020, the research team published a rapid report on COVID-19 and homelessness, which found that in Ontario, people with a recent history of homelessness were significantly more likely to have a positive COVID-19 test result compared to the general population. The overall goal of the Homelessness Count study is to refine and scale this homelessness algorithm to get better national numbers. The Homelessness Counts project is a national 4-year research project with 5 main research objectives. For the purpose of this presentation, I will elaborate on objective number 1, which corresponds to year 1 and year 2. We completed a primary mixed method data collection of at least one community in each province and territory across Canada. We conducted interviews with people who were experiencing homelessness and also held focus groups with different community stakeholders. Other research objectives include refining the homelessness algorithm, generating enhanced risk and burden modeling, integrating components of machine learning and artificial intelligence, and then going back to the various data collection communities to hold forums, to share project outcomes, share key findings, and provide opportunities for knowledge exchange. For this specific analysis, we focused on issues impacting rural and remote areas of Canada to provide a deeper and more comprehensive understanding of the various dynamics of homelessness, including the impact of the COVID-19 pandemic. As you can see from the map, we visited various communities all across Canada. March in particular was a very heavy data collection month, and a lot of that data is still being entered and validated. So for the purposes of this analysis, we included 277 participants from 21 representative communities across Canada. The total sample size is now actually up to 386 from 27 different communities. But for the purpose of this analysis, we found that 62 lived in smaller and more remote communities, whereas 215 lived in larger urban areas. We also conducted virtual focus groups with 145 community stakeholders. For the purpose of analysis, data collection sites were divided into 2 main categories. The first was remote areas or small population centers. These are areas with populations of less than 30,000. And the second was mid to large population centers, so any areas with populations greater than 30,000. For the urban population, the majority of the sample reported having one psychiatric diagnosis, with the most common being a mood disorder. Most participants identified themselves as being of European origin. This stood in contrast to rural and small population centers, where a higher proportion of the sample reported having multiple types of psychiatric diagnoses. Of those who reported at least one diagnosis, substance-related disorders were the most commonly reported. Most of the participants in these locations identified themselves as being Indigenous. In both of the 2 main categories, the majority of participants reported having criminal justice involvement. Several participants also identified as members of the LGBT2+ community. Although a more comprehensive qualitative analysis of the data from focus groups is currently in progression, emergent trends related to homelessness in more rural and remote communities across Canada were constructed and organized into 3 overarching themes. 1, a rise in first-time homelessness. 2. Lack of available housing and support services. And 3. A growing number of people who are living in the rough. Preliminary findings from individual interviews showed several factors that facilitate access to services and supports for people experiencing homelessness. Such facilitators include 1. Access to appropriate communication technology, 2. Accessible outreach and community services, 3. Accessibility of integrated community services, and 4. Peer support or access to information offered by persons with similar experience. The study findings also showed that people who are experiencing homelessness are faced with a wide range of barriers that limited their access to community services and supports. The study findings identified barriers such as 1. A limited access to information about available community services, 2. Uncomfortable feelings due to stigma and discrimination, 3. Strict housing application requirements, 4. Ineffectiveness of housing systems, and 5. Limited access to available resources without a photo ID. In conclusion, the goal of the Homelessness Count study is to come up with a better method of determining who and how many people are experiencing homelessness in Canada, to hopefully provide policymakers, researchers, and practitioners better insights to help inform interventions, services, and potentially funding allocation decisions. Quantitative findings show demographic variations between urban and rural small population centers. In particular, in rural and small population centers, a higher proportion of the sample reported having multiple types of psychiatric diagnoses, with substance-related disorders being the most common. Moreover, most of the participants identified themselves as being Indigenous as opposed to being of European origin. Qualitative insights from focus groups with community stakeholders identified 3 overarching themes: a rise in the first-time homeless, lack of available housing and support services, and a growing number of people living in the rough. Similarly, qualitative insights from interviews with persons with lived experience identified several facilitators and barriers to accessing services and supports. And just before we go, I thought it would be fun to share some photos we captured from the various data collection sites